Thank you so much, Greg. And it's a real pleasure to be here this morning and to see everybody and to see everybody at home as well. So essentially what I want to do over the next 20 minutes, and I'm going to take my watch off so I can make sure I don't do too much talking, because for those of you who know me, I love to talk. I want to talk a little bit about MGUS, okay, monoclonal gammopathy of uncertain significance. Sometimes it's called undetermined significance, okay. And just to start off with, it's just great to be back. It's going to be a successful day, I know that. And I think we've all got a cup of coffee in the room, and I'm going to give you all a good virtual hug, because that's always a great way to start the day. But unfortunately, we're going to need to spoil it for a few minutes, because we need to talk about some biology and some science before we get going, okay? Because I want to set the scene for the rest of the day, so we need to do a little bit of basics, if that's okay, before we get going, okay? So let's have a little think about what happens in somebody who doesn't have a problem with either MGUS or myeloma or any of these other disorders that are related. So we're essentially thinking that within our bones, and in an adult, it's our long bones, so our big bones, the feet, the top of the legs, the hips, the spine, top of the arms. That's where we make our bone marrow, and it's our bone marrow that makes our blood cells, so the ones that give us energy, the ones that fight infections. And the cell that we're particularly interested about is what we call a plasma cell, okay? And in somebody who hasn't got a problem, they normally have about 5% of those in the bone marrow. So when we look at the bone marrow, we see cells that make your blood and so on. We see about 5% of these plasma cells. And what their job is to do is to make antibodies that fight infections, okay? So for instance, if you get COVID, you'd make some antibodies that fight COVID, or if you have the measles, then maybe you make some antibodies to fight the measles. What can happen, though, is that these cells can go awry. They can no longer are under any form of control, and they start to grow, okay? And so we end up with these abnormal cells. And rather than these abnormal cells making antibodies to lots of different disorders, they just make one antibody. Okay, and that's my picture at the top there of a kind of Y, which is our picture of the antibody. Okay, and essentially what we call this antibody when it's made from cells which are abnormal is our monoclonal protein, or sometimes we call it the M protein, or if we have any European kind of people listening, then we call it the paraprotein. And essentially what we have now is a whole group of disorders which will make this M protein. And we can measure that in either the blood or the urine. And so it's a family of disorders, okay? And so of which myeloma is one of the members of the family, but there's also lots of other members of the family. Okay, so in this picture, you can see this is some work done by the group at the Mayo Clinic, and Dr. Kyle, who is one of the kind of incredible investigators who've been looking at these disorders for years and years. And he followed a group of a county of people and was looking to see how many of them had this small protein in the blood or the urine. And what he discovered that yes, about somewhere just under 20% of people in this county had evidence of myeloma in their blood or urine, but there was also a large group of patients who had this condition called MGUS. And so we're going to concentrate on that in a little bit more detail. But it's just to say that when people come to the clinic with a protein in their blood, what the doctors are trying to do is trying to decide whether it is a disease called myeloma that needs treatment, whether it's something called MGUS, which doesn't need treatment, or indeed whether it's one of these slightly rarer conditions, which will also present with a protein. And that can sometimes be something like CLL or Waldenstrom's, so other kinds of blood disorders, smoldering myeloma, which we're going to hear about afterwards, okay? Or sometimes patients can actually have a slightly kind of hybrid disorder where they maybe have one bone problem, but the rest of them is they don't have lots of bony problems. So I've kind of tried to draw that out in a bit of a simplified way. So on the left-hand side, we've got this disorder that I'm talking about, this MGUS. And then on the right-hand side, we've got myeloma. And the main difference as far as symptoms is concerned is that myeloma presents when patients have problems. So it might be aches and pains or fractures in the bones. It might be problems with the kidneys. It might be increase in infections, or it might be low blood counts. Whereas MGUS does not have, or in the majority of cases, does not have any symptoms related to it. So I can hear a few people thinking, well, how on earth do you know if you've got it or not? Okay. And that's exactly one of the problems. Most of the patients or people, I can say, I'm not sure you can be a patient if you don't have anything wrong with you. Most of the people who have this actually come to us when they've gone to hospital for something else and it's been picked up accidentally in the blood test. Okay, so one of the things that we can find is that these patients have a low level of protein, this M protein, in their blood or in their urine. And often patients will have come potentially, I don't know, maybe had a prostate operation, or maybe had a hip operation or something completely different. And then somebody very observant kind of has looked at the blood and has noticed this. If we go on and do many of the tests that we would do to diagnose multiple myeloma, we find that patients have some of the same characteristics on those tests, but usually a little less of them. So potentially if we do the bone marrow for patients who have myeloma, we'd expect to find more than 10% of those abnormal cells in the bone marrow. Whereas if we do that in a subject who's got MGUS, then those people will have less than 10%. And as I say, if we do X-rays or CT scans or MRIs, we'd expect to find a patient with myeloma having bony problems, whereas those people who have MGS don't have any issues or problems with their bones. So having said that, why are we interested in MGUS? And the key thing is that some patients with MGUS can actually go on to develop smoldering myeloma, which we're going to hear about in a little while, or indeed go on to develop myeloma. And there's been some interesting work done by Dr. Langren, who looked at patients in the VA system and was able to show that actually many patients who had myeloma had previously actually had MGS and they never knew about it. Okay. And so it's important to kind of look at these patients with MGUS because, as I say, some of them are going to go on and get myeloma. And the question is, which ones and how do we figure that out? Now, in addition to those kind of subtleties about going on to myeloma, there's a couple of other things that as a doctor, we need to be very careful of, because patients that have a low level of cells in the bone marrow can potentially have other things going on as well. Okay, and I don't know if we have any amyloid patients in the room. I'm sure we probably have some listening online, but that's another disorder that can sometimes look like MGUS, but actually is a slightly different kind of sister or cousin to that, in the fact that amyloid patients, when they make their M protein, that M protein actually gets stuck in many of the tissues and builds up in many of the tissues and causes damage. So it can cause damage to the heart, or it can cause damage to the kidneys. There's another condition, which is again a little bit of a hybrid condition, in the fact that some patients can have a low level of the protein, but can actually just have one area where they've got bony problems. And then the third one is one that we've been recognizing more recently and has recently got a name, okay? So rather than MGUS, where the U stands for undetermined or uncertain, it's called MGCS, which means clinical significance. So we know that those patients have a protein, but it's not that they don't have any symptoms. They don't have myeloma, but they have some symptoms related to that protein. And so sometimes that protein might be damaging the kidneys. One of the common ones is sometimes that protein can actually damage the nerves, and patients can have pain or tingling or coldness and hotness in the limbs. And occasionally it can be associated with some of the skin conditions, so some kinds of rashes and so on. And so there's a number of subtleties around these different diagnoses, which is the important reason that's to know is that when somebody with a small protein gets referred to their doctor. Now, you're not meant to see this, okay? So don't worry too much. It's just to say that as a doctor, we're looking to try and figure out exactly which one of those different groups a patient falls into. And we have some guidance to help us do that. And it's based on the type of protein the patients have, the level, how high the level of the protein is, and whether the patient has any other things going on, like problems with their kidneys, problems with their bones, problems with their skin. Okay, so there's some very specific kind of guidance that helps us put the patient in the right group so that we know and we can discuss how things may or what may happen for an individual patient. Okay, so why am I talking about this? This is a slide I borrowed from one of my friends who's French. So the observant people in the room will notice that it doesn't say years, it says ans. But the reason I'm talking about this is because it's actually quite common to have a low level of protein in your blood, okay? And it gets more and more common as you get older. Okay, and so if you look, it's nearly about 20% of people over the age of 90 will have a low level of protein in the blood. Now, clearly, 20% of people have MGUS. They don't all go on to get myeloma. And so the question is, which patients do go on and get myeloma, and can we tell? Okay. And again, not supposed to be particularly red. And anybody who's in the room, I'm sure if you're at home, you'll be able to see the slide a little bit better. But if you're in the room and you want to talk about this with me later, then please come and grab me. But essentially what we do when we have a patient, we initially try and determine what kind of problems this small protein is giving the patient. Okay, and so we're going to do that based on their blood count. Are they anemic? Based on their kidney levels, are the kidneys working okay? And then we're going to measure the actual protein and find out what kind of protein it is and what level the protein is. Unfortunately, we're also going to have to do the bone marrow because we need to know how many plasma cells are in the bone marrow, because we need to make sure that we're not dealing with myeloma here and that we're dealing with this condition that doesn't cause any problems. Okay, we're also going to do some scans, either a CT scan or an MRI scan, or maybe some X-rays. X-rays aren't our favorite, but we're going to do that with a view to trying to decide if there's any bone problems. If the patient's complaining of nerve-like problems, so problems with their fingers or their legs or what we call neuropathy, then we're going to check a special test to see whether that protein actually attacks the nerve endings. We're also potentially going to see if the patient's got shortness of breath. We're going to have a little look at their heart and see whether that protein may be affecting the heart. And all of those tests are going to help us determine exactly what the problem is and how we should be looking at it in the future. And the main thing we're trying to do is we're trying to detect, number one, whether it's going to give the patient any trouble, because I'm not sure how many people are in this room, but if you probably not far off at that number, but if we think about it, only one of these patients that has a high level of protein in their blood is actually going to go on and get myeloma that needs treatment. So that means there's going to be 99 other people where it's not a problem. So it's a little different if you think about it to maybe breast cancer, where because a lot of people say, why don't we just test everybody in the world and see if they've got a protein, like you do with your mammograms where you're looking for breast cancer, or your smears where you're looking to see cervical smears, whether you've got any kind of precancerous cells. And the problem with that is that we know that if we do a mammogram and you've got a lump, we kind of know that's going to go on to get breast cancer. If you've got a few abnormal cells on the smear, or indeed a high PSA level on a prostate scan, we know that has the potential to go on. Here, what we're saying is that only one of those patients is actually going to go on and get a problem. And that means that we've got 99 people who are going to be worrying, or potentially worrying, about whether they've got a problem or not. So what do we do if you are one of those 100 people or whatever that have got that protein? What do we do about it? So first, what we're kind of looking at is there's not one factor that tells us who's going to go on and get a problem. Okay, we have to take the whole person together. Okay, so we do know that the type of protein can make a difference. So we know that if patients, when they get their M protein back, there tends to be 3 kinds of M protein, or potentially 4, an A, an M, a G, and a D. Okay, and we know that patients that have an IgA have a slightly higher tendency to go on and get a problem. We know that the level of the protein can also give you a tendency to move on and get a problem. We also know the other test that many patients will have is this serum-free light chain. And we know that patients who have an abnormal ratio of that can go on and get a problem. Okay. And we also know a little bit about some of the genetic tests that we may do. And that's not genetics as far as passing it on to family members, it's genetics within the actual myeloma cell. But it's not one thing, it's a collection of things. And what many of the scientists are currently trying to do is trying to build models. You know, everybody's talking about artificial intelligence and that kind of thing, trying to build models so we can try and predict who it might be that moves forward and get a problem. But at the moment, often patients actually, we can't predict, and we have to actually follow patients closely. So how do we do that? We do that really by seeing them relatively regularly. So if a patient has been recently diagnosed with a protein, then we will check it about 6 weeks to 3 months later to see if it's stable. Because the key thing here is we know that if you've got MGUS, if it's just low and staying quiet, that's okay. We don't mind that. It's not doing any damage. What we're looking for is if it's slowly climbing up, then we're thinking, okay, at some point, it's potentially going to do some damage. Okay. And so usually during the first year after a patient's been diagnosed, what we'll try and do is try and see them relatively often, you know, every 3 months to 6 months, to check that it's doing this. The actual frequency, again, is very dependent on the patient. Okay, if it's a really low level, then we probably don't need to see them that frequent. If it's a slightly higher level, then we do need to see them a little bit more frequently. And then the other thing, obviously, is if the patient develops anything unusual. So if they suddenly develop some pain or something like that, then clearly we need to see them a little bit more frequently. But the idea is that usually within the first year, we see everybody quite frequently, but then it becomes more of a kind of, okay, like you do your annual physicals or whatever, you potentially end up having to see the doctor for those blood tests every 6 to 12 months. So I think just in closing, one of the things that we do need to think about is, okay, that's lovely. You've told me that the majority of people is going to stay quiet and good. What about that one person where it's actually going to go on and cause a problem? Is there anything we can do to stop that happening? Okay. And I think at the moment, the truthful answer is no. Okay. And I know that we're going to have a talk about smoldering myeloma later. And that's where we're looking at this in a little bit more detail. Okay. And the reason at the moment I think the answer is no is if you think about it, if we start treating people with MGUS, that means that we would give those people treatment for the one person that's actually going to make a difference to. We're going to treat 99 people where it ain't going to make a difference. Okay. And that's okay if it's a very simple treatment that doesn't give any side effects. It's worth it, if it was a vitamin or something, like that. But if it's actually chemotherapy or something like that, then that's an awful, it's not kind of the right risk balance there. We're probably causing more damage than we can think. And so many people are studying this and looking at it really very closely. And I just wanted to call out this study, which is called the iStop myeloma study. Okay. And the reason I want to call it out is because I think you'll be hearing quite a lot about it in the next kind of year. We haven't seen the results yet. I think, as everybody knows, there's a big meeting that always happens in December where all of the doctors get together. And this is one of the studies that's going to be presented there. Now, one of the kind of advantages about Iceland is it's an island, okay, and it has very little kind of movement of people, okay. And so what the physicians and scientists have done in Iceland is that they are looking at the whole population with respect to checking this protein in the different people, okay, giving them questionnaires to look at risk factors and what they've been exposed to in the past, also giving them some questionnaires about quality of life and about kind of psychiatric health issues, and so that we can really see and figure out about what happens if patients know they have an M protein. Can we figure out why some might move forward or not and others don't? Okay. And as I say, the first kind of data from this is going to be released in December. And I don't know if Cindy is actually in the room, but I'm really going to encourage the Greg and Cindy and the other myeloma crowd people that do the kind of stuff for the website and for the university to kind of do some work around making sure that patients get to see this data in December and January, because I think it's going to be really important. It may not be important now because they're at the beginning of the study, but as we go over the years, we're going to see exactly what's happening with these people with these low proteins. So I'm going to finish there. I have no idea how long I talked for, but there we go. And I'm going to pass it on and hand it back to Greg, and then I'll take questions and everything later on. Thank you.